This is an update video. The Resuscitation Council of UK have come up with the latest 2025 updates or latest updates in their algorithms. So we'll be going through this algorithms and seeing what are the changes. I'm not going in the depth. I'm just concentrating on the changes. The first algorithm what we are seeing is the adult advanced life support algorithm for the cardiac arrest. So this is a cardiac arrest algorithm what we are looking out for. In cardiac arrest algorithm, most of the things remains the same except one thing. This is the thing what has been changed here. Change the pads to AP position, that is anterior posterior position after 3 shocks. Usually we place the pads in this position. Okay, they want you to change it to the anterior posterior position after 3 shocks. So basically it means that the positioning what you are doing might not be delivering the adequate shock in a shockable rhythm. That's why after 3 shocks, if they have failed for the fourth shock, change it to the anterior posterior position is the latest recommendation what you need to be aware of. Post cardiac arrest, once you get it and ROSC, what you're gonna do? That is known as adult post-resuscitation care. Much of it remains the same with few changes. First one, airway and breathing, it has remained the same, where you maintain the oxygen. If required, you will be intubating the patient to maintain an oxygen saturation of 94 to 98%. Insert advanced airway. As I told you, once you are inserted, confirm with a waveform capnography and ventilate the lungs so that especially the PaCO2 remains in the normal range and PaO2 is also in the normal range. These are the two targets what we are having whenever we intubate and connect the patient to the mechanical ventilator. In circulation, we need to always get end-to-end lead ECG done. We shouldn't be forgetting about get and reliable, a good large bore IV cannula, at least one, if not couple. Maintain the blood pressure of systolic more than 100 millimeters of mercury. First, assess the patient and see whether he is hypovolemic. If hypovolemic, give fluids and make sure he is normovolemic. Make sure the patient has an intra-arterial line so that you can continuously monitor the blood pressure. If the patient is already normovolemic, still hypertensive, at that point of time, you need to start on inotropes or vasopressors to maintain a systolic blood pressure of more than 100. So the target is more than 100. Prevent fever by giving antipyretics if required. Do not allow the patient go into the fever. It is a poor prognostic factor. Then you will ask yourself, do you think the cardiac cause is likely? For example, the chest pain what he has presented with or the breathlessness what he had, most likely because of pulmonary edema. It is a cardiac cause. No, it is unlikely to be a cardiac cause. This was a trauma. There was an or this was basically an complication of sepsis. We are not thinking of a cardiac cause. Then we directly go to this. What if we think of it is a cardiac cause? We reassess the ECG what we have taken here. So we have taken an ECG here. Look at the ECG closely. If the ECG suggests there is an ST segment elevation, one thing, or if the ECG has anything which is suggestive of an tachycardia or blocks, any blocks, a complete heart block, or it might be a Morbus type 2 block, any blocks are present, or the patient is unstable. Okay, these are the three indications to directly go ahead and get an angiography done, plus or minus percutaneous intervention will be done. If this is not effective or none of these features are present when you assess the patient, then again go to this pause. Here what they say, get an head to pelvis CT scan, completely scan. From head to the pelvis you scan it. Previously it was recommended that get an CT head and consider getting an CTPA done. That is CT head and CT chest, you are getting it done. Here they want you to scan completely from head to pelvis, include everything there what they are recommending. If you found out by now what is the obvious cause for the cardiac arrest was, treat the cardiac arrest and admit in the ICU. Once you are admitted in the ICU, what is done in the ICU is more for the intensivists rather than the emergency medicine physicians. Now coming to the tachycardia and bradycardia. For tachycardia and bradycardia, they have elaborated what do they mean by life-threatening features. They mentioned using different terminologies so that it is very clear. So we need to think in that manner now. Shock. What do they mean by shock? They mean by shock is whenever there is reduced perfusion to the end organs. First end organ what we are seeing is the CNS. CNS reduced perfusion because it might be suggestive by the patient having low GCS. The patient is confused, patient is drowsy, suggestive by decreased perfusion of the CNS system, central nervous system. Whatever the peripheries, skin basically we are talking about. Decreased perfusion will result in cold, clammy skin. Capillary refilling time will be prolonged. The pulse what you palpate for will be weak and thready. If the kidney's blood supply is reduced, the kidney output also will reduce. So there will be reduced urine output in these patients. Syncope with severe or ongoing hypotension. So what do they mean by this? Someone who has collapsed or fainted, having a blood pressure of less than 90 millimeters of mercury. So it's a combination of this. What do they mean by? So it's only syncope, no. Syncope with a severe or ongoing hypotension. This should be present to really call it as a life-threatening feature. Myocardial ischemia, a typical chest pain he should be having. For example, a crushing chest pain or heaviness what he is having on the left side, it might be radiating into the jaw or radiating into the left arm. Is a typical feature. Or you get an ECG done, which is suggestive of an ischemia by suggestive of an ST segment depressions, or it might be suggestive of an STEMI itself, a full-blown myocardial infarction by ST segment elevations. Severe, remember the word severe heart failure and pulmonary edema or pulmonary edema. Severe it is. It is not a mild what they are talking about. So the patient might be having severe breathlessness, which is suggestive of he might be bringing out being frothy sputum. He might be having crackles in his chest when you auscultate for. Fine crepitus might be present. This is not only basal fine crepitus what you're seeing in the lungs. It should be at least at the mid zone or upper zone. If it is only basal, then it is more suggestive of a mild to moderate, not in severe heart failure, low saturation. So any one of this following is present, then you need to consider it is a severe heart failure or severe pulmonary edema. Then you need to consider it as a life-threatening feature. Immediate post-ROSC. That means you have just acute the return of spontaneous circulation. Okay. Then the patient started having a tachycardia or bradycardia. Then it becomes a life-threatening features. If life-threatening features are there, what we do? We go ahead and shock the patient. It is a synchronized shock what we are giving here because we are expecting the patient to be alert, awake. Whenever the patient is awake means not in cardiac arrest I'm talking about. Better terminology, let me use it, not in cardiac arrest. Whenever the patient is not in cardiac arrest, you're doing a synchronized shock. So these are the same life-threatening features what you will be seeing in tachyarrhythmias as well as in bradyarrhythmias. So now let us talk about the adult tachyarrhythmias. The ABCD assessment, what we have learned remains the same. Life-threatening features is the modified one, what we have just learned now. That is the life-threatening features for both tachyarrhythmias as well as bradyarrhythmias. If any of these life-threatening features are there, we're gonna shock. If the patient is awake or alert or partially conscious, you need to sedate the patient before you shock. So you are giving unconscious sedation before you shock, and this conscious sedation needs to be given by anesthetic. So you give 3 shocks. One shock you give reassess, no, patient has not reverted back to the sinus rhythm. Second shock not reverted, third shock not reverted. For the fourth shock, before you give fourth shock, you are giving amiodarone. That was very much similar to the previous guidelines. Now they have added, instead of amiodarone, you can also give procainamide. Remember, you can also give procainamide. What is the dose? You can give it around 10 to 15 mg per kg. Max, you can go till 1 gram. Do not go beyond 1 gram. Once you are given a bolus of either amiodarone or procainamide, not that one is superior over the another one, you can choose any one of this. If once you are given it, the second step will be to give the synchronized shock. This is the fourth shock what you are giving. If the patient doesn't respond to the fourth shock also, you are involving the cardiologist. You need to take cardiologist opinion. Something seriously wrong here. So you need to take cardiologist opinion. The energies remains the same what I mentioned in the class previously. It's the same, nothing different is here. This part of the algorithm doesn't address every possible scenario. That means once the patient is not having any life-threatening features, they clearly mentioned that this part of the algorithm does not address every possible scenario. But nevertheless, the algorithm is very important. It is ALS. We need to understand here. So let us see what we need to be really focusing on. First, what we see is the QRS complex. QRS complex, once the patient is stable, what we see, that means once the patient doesn't have any life-threatening features, we see at the QRS complex. Is the QRS complex narrow or is the QRS complex broad? If the QRS complex is narrow, that means less than 3 small boxes. Then we see whether the QRS complex is regular. The rhythm is regular or irregular. If it is irregular, then we are always thinking of an atrial fibrillation. Treat the atrial fibrillation, what we have learned in the cardiology chapter accordingly, because this is very simplified version. They are not gone in depth. They're not considered structural heart diseases here. They're not considered if it's a known case of heart failure here. They're not considered the duration of more than 48 hours or less than 48 hours. So my recommendation is follow what we have learned in the cardiology chapter. Next one is, what if it is a narrow QRS complex, but the rhythm is regular? If the rhythm is regular, we are most of the time thinking it as an SVT. The treatment of the SVT has remained the same. It has not changed. First, what we do an vagal maneuver. If that is not effective, then we give 6 mg of adenosine via the anterior cubital fossa. A large IV bore cannula will be followed by fresh rapid infusion or rapidly you need to give it, because it has a very small half-life of few seconds. If that is unsuccessful, we can give 12. If that is also unsuccessful, we can give it 18. So what we're doing, first step is vagal maneuver. Second step is giving 6 mg. Third step is giving 12 mg. Fourth step is giving 18 mg. It has remained the same, no changes. It's still not effective. It is unlikely to be an SVT. It might be an atrial flutter. So atrial flutter, we usually treat it with a calcium channel blocker like verapamil or giving an beta blocker. If still not effective, we are going ahead with an synchronized shock. For synchronized shock, conscious sedation will be required if the patient is not unconscious. Okay, if the patient is conscious, he has to be conscious because the patient is stable here, then you need to do an synchronized shock by giving conscious sedation. Next one is the QRS is not narrow, it is broad. It is more than 3 small boxes. If it is broad and regular, what we do this. This is a little bit complicated. That's why I have broken down it for a better understanding. It might be an SVT with aberrant block. So you're sure that it is an SVT with an aberrant block. Then what you do is you treat it like an SVT. So it is an SVT with a bundle branch block like an LBBB, or it might be an RBBB. Okay, that's why it is appearing as a broad QRS complex because of the blocks what are present here. And it is an SVT, so it's a tachycardia. So it's a regular broad complex tachycardia what the patient is having because of an SVT with one of these blocks. You need to be doubly sure that that is. If that is, you're sure, then you can do an vagal maneuver. If that fails, do an adenosine, give an adenosine and 6 mg, 12 mg, and 18 mg. It remains the same. You treat it like an SVT. Next thing is, you're sure that it is an VT. Okay, it's a ventricular tachycardia, you're sure. Or you might not be sure, you're not sure it is an SVT with an aberrant block or it is an unknown VT. Sorry, it's a known VT. That means I'm sure that it is VT, or I'm sure that it is SVT with aberrant block. I'm not sure, I'm uncertain. Or the patient is a known case of heart failure or suspected case of an heart failure. Or you are sure that it is SVT with aberrant block, so that you are given an adenosine, but adenosine or vehicle maneuver adenosine was ineffective. In all these 4 circumstances, the preferred drug to be given is procainamide. This is the new procainamide. In the new 2025 guidelines, they're stressing or they're leaning towards procainamide. Remember, procainamide, what you'll be giving. How much you'll be giving? 10 to 15 mg per kg over 20 minutes, what you'll be giving. Max what you can give is 1 gram. Especially consider giving procainamide over an amiodarone whenever there is an high risk for conscious sedation. For example, he has plenty of comorbidities. Okay, he's an obese individual. It is a high risk for giving in conscious sedation. If you give conscious sedation, he might go into the respiratory arrest. You're worried because if a drug what you're giving is ineffective, what we do, we go ahead and shock the patient. If ineffective, we go ahead and give an synchronized shock. For synchronized shock, conscious sedation is required. So especially they have stressed that, especially when there is a high risk for conscious sedation, give procainamide. Okay, so we know it is a known VT, or you're not sure with a VT or an SVT with aberrant block, or SVT with an aberrant block you thought and the treatment has failed, or he is a known or suspected the case of an heart failure. In these cases, we go ahead and give an procainamide. What if the procainamide is not available? Because it's a new drug. Just now they started. Before this, we used to not use procainamide a lot in the resuscitation bay. What if it is not available? What if it is contraindicated? Remember that it is contraindicated in severe heart failure. If it is severe heart failure, it becomes a life-threatening feature. So do not worry. Anyways, we end up giving shock. What if it is an acute MI? We end up giving shock. So one contraindication, what you need to be aware of is end-stage renal disease. If it has an end-stage renal disease, we prefer giving amiodarone. The dosing remains the same, that is 300 mg IV over 10 to 60 minutes, followed by 900 mg over 24 hours. That's what is been recommended. Now, we have an broad QRS complex. That means more than 3 small boxes, and it is irregular. Then what we do, we go through this. Let us break it down so that we have a better understanding. So it's a stable, broad, irregular QRS complex. So it can be an polymorphic VT, also known as torsades point, is most of the time it is with an QT prolongation. It's the QT prolongation initially which predisposes to polymorphic VT. Or it can be an AF with pre-excitation. That means AF with an accessory pathway. For example, LGL, or for example, WPW, what we have already learned. And as we learned in the cardiology chapter, when we learned about the treatment of atrial fibrillation, you either give proconamide or flecainide or do an cardioversion. Flecainide, they are not mentioned. They are mentioned proconamide, cardioversion, what they have mentioned. And ideally involve the cardiologist also at the earliest. So proconamide is the drug or a cardioversion. If you ask me out of both, which is preferred, cardioversion is preferred. Second line will be proconamide. Always involve the cardiologist. It is difficult to treat. What if it is an polymorphic VT with an QT prolongation? Is the magnesium what you're giving? Here they have mentioned it as an 8 millimoles. 8 millimoles, what they have mentioned in the new algorithm. If you see here, they have mentioned here 8 millimoles to be given over 10 minutes. Is it different from what we have learned previously? No. 8 millimoles means 2 grams itself. In previous algorithm, they had mentioned it as 2 grams. Now they have mentioned it 8 millimoles. It's just the unit has changed, but the quantity what you're giving has remained the one and the same, and you're giving over 10 minutes. Once this polymorphic ventricular tachycardia goes into a sinus rhythm, what they have advised, that's the step 1 to give magnesium sulfate. Once VT is subsided, then you go into the step 2. Step 2, what they are told is keep the heart rate on the higher side. Do not allow the patient to go into the bradycardia. For this, if required, use isoprenaline or use an temporary pacing to increase the heart rate. Why? It is the bradycardia, or it is the prolonged QT interval which usually predispose to ventricular tachycardias. Okay, polymorphic ventricular tachycardias. So they want to address both of this by increasing the heart rate. So bradycardia, by increasing the heart rate, yes, we know it works. What about the prolonged QT? How does it work? As the heart rate goes on increasing and increasing and increasing, the QT interval, not the corrected QT interval, just the QT interval becomes smaller and smaller and smaller. That's the logic here. So they want to keep the heart rate on the higher side. For that, if required, use isoprenaline, or if required, use transcutaneous pacing, what they are recommended here. So you can see here, consider isoprenaline. So this is not the first step what they're telling you. First step still remains the same, giving magnesium. Do not give it when the patient is having a polymorphic ventricular tachycardia. It will be disastrous. Once the polymorphic ventricular tachycardia is subsided, then only you're using an isoprenaline or an temporary pacing to increase the heart rate, to keep it on the higher side. For example, keep it on around 100. Okay, so it doesn't go into the bradycardia and doesn't have a prolonged QT interval. Hence, you are preventing the recurrence of an torsades, or also known as polymorphic VT. Adult bradyarrhythmias. So bradycardias, whenever they are having, we always go with an ABCD assessment. It is similar to the previous guidelines itself. ABCD assessment. If the patient is hypoxic, you will be starting them on the supplementary oxygen. Get an 12-lead ECG done. Connect to the cardiac monitor. Identify and treat the reversible causes. Once you have done this, then only we are looking out for life-threatening features. These life-threatening features are same for tachyarrhythmias and bradyarrhythmias. They are not different. They are one and the same itself, which we have learned in the previous slides. If there is a life-threatening feature, then we immediately give a dose of atropine. That is the 0.5 mg IV. We give the dose of atropine and look out for the response. Is the response satisfactory or unsatisfactory? If it is unsatisfactory, then we repeat multiple doses of atropine to a max of 3 mg. So total of 6 doses of atropine can be given. So 6 into 0.5 mg what you are giving, it comes to 3 mg. This is the maximum dose what you can give. If atropine fails, then you have a choice either to go ahead with a transcutaneous pacing or start with one of these drug infusions. The preferred one is to start with a transcutaneous pacing. So go ahead and choose transcutaneous pacing over any other infusions. If the transcutaneous pacing is not working, or the one of the infusions are not working, at that point of time you need to seek the expert's help. Okay, why expert's help? Who is the expert here? You need to seek the cardiologist help. Cardiologist help for pacing and transvenous. Okay, transvenous pacer, you want it here. Now we'll go all the back up here in the algorithm where life-threatening features are not present. What you will do, you will directly go ahead to this box and look out for are there any risk factors for asystole. Okay, if life-threatening features are present and atropine are given and you assess for the response and the response is satisfactory, then again you come back to this box itself, that is risk for asystole are present or not. What are the risks for asystole? Recent asystole, morbid type 2 AV block, or complete heart block with broad QRS complex, or ventricular pause for more than 3 seconds. Ventricular pause for more than 3 seconds means a QRS complex appears after 3 seconds itself. In between, there are no QRS complex. That is known as ventricular pause for more than 3 seconds. Recent asystole means recent cardiac arrest. This patient had a recent cardiac arrest. Asystole means morbid type 2 AV block or complete heart block with an broad QRS complex. If any one of this following is present, what we do, we immediately seek again cardiologist help for an transvenous pacing. You monitor, you treat if there is an underlying cause, and always consider for an transvenous pacing. If none of the following are present, what is mentioned in the risk of asystole, then you just observe the patient. That is all about the bradyarrhythmias. The changes to be more precise and to let you know what exactly has been changed from the previous algorithm is here. If there are no life-threatening features, you directly assess for the risk factors of asystole. Okay, once if there is a risk factor for asystole, we used to give one of these interim measures. The interim measures have not been given, or they're asking you do not give any interim measures. If there is a risk of an asystole is present, directly seek cardiologist help and directly go ahead with an transvenous pacing. Another change to be more precise is the life-threatening features, which is same for both tachyarrhythmias and bradyarrhythmias, which have been changed in 2025 Resus UK guidelines. Pediatric adult life support. Only one thing has changed here. That is this part which is being changed. Previously, what we used to tell is give 4 joules per kg whenever it is in shockable rhythm. Here they says first 5 shocks. Okay, first 5 shocks, give it at 4 joules per kg. Then from the 6th shock, keep on incrementally increasing. For example, you're given 4, increase it to 5 joules per kg. Next, increase to 6 joules per kg. Next, increase to 7 joules per kg. Next, increase to 8 joules per kg. Up to 8 joules per kg, you can increase it. For a max of 360 joules, what you can increase. Do not increase more than this, what they are recommended. So previously, it was only 4. Now they are recommended, you can go incrementally increase it and go up to 4 joules per kg, you can go with. That has been recommended. That's the only change what you need to remember. Rest everything remains the same. Newborn life support, everything remains the same. They have just changed the algorithm a little bit so you get a better understanding. Otherwise, it has remained the same. Okay. If there are any changes, I'll let you know now. First, what you do, you start the clock, delay cord clamping, stimulate, and thermal care needs to be taken. Okay, make sure the baby is warm. And assess for breathing, heart rate, and tone. You're not assessing for color here. Color has been omitted out. It's not been mentioned. Ensure an open airway and start giving adequate breaths. What you're giving, 5 inflation breaths, what you're giving at the room air at a pressure of 30 centimeters of water. If possible, you can give PEEP also at 5 to 6 centimeters of water. Start with an SpO2 monitoring here. If 3 lead ECG is available, that means cardiac monitor is available, please connect it. And start reassess the heart rate and chest rise. First thing what you're concentrating is on the chest rise. If chest rise is moving, okay, so if chest is moving, so you give 5 inflation breaths. After giving 5 inflation breaths, if the heart rate is still less than 60, then you give continuous breaths for 30 seconds at a rate of 30 per minute. That means you're giving 15 breaths over 30 seconds you're giving and reassessing for the heart rate. So let me repeat it so that there is no confusion whatsoever in your exam. It's the same algorithm. It has not changed that much. Only here color was there, which is not mentioned here. That's the one thing what has been changed. Rest everything remains the same. So you're trying to give 5 inflation breaths. 5 inflation breaths, when you're giving it, you're always looking for chest rise. If chest rise is yes present and you're given 5 inflation breaths, then what you're checking? You're checking for the heart rate. Is it less than 60 or not? If it is more than 60, then you achieved your targets. No, if it is less than 60, what you do? If it is less than 60, then you're giving continuous breaths at 30 per minute. Okay, for 30 seconds you're giving. Then again, you're reassessing if the heart rate is less than 60 or not. If it is less than 60, what you do? You start the chest compression at at 3:1 ratio. Then reassess after 30 seconds. This is the algorithm what you need to follow. After reassessing after 30 seconds, what you'll reassess. Still the heart rate is on the lower side. What you do? At this point of time, you go ahead and sorry. At this point of time, you go ahead and get an IV or vascular access. Okay. You check for any considered drug or intravascular volumes are reduced or not. You start checking for the glucose. You're thinking whether the patient is having a pneumothorax or any congenital heart diseases or any other abnormalities and metabolic disorders are present. Okay. By this time, we expect that the neurologist will be there and you will go ahead and update what has happened to the parents and record everything what you have been done so far. Remember, here you need to start at 100% oxygen. Here, when we are giving inflation breaths, we usually give it at room air. Okay, we are just giving at the air. We are not adding FiO2 or we are not giving supplementary oxygen. Here, we are giving completely a supplementary oxygen. That means 100% oxygen here, what we are giving, what you need to remember. It's important. What if you're not seeing the chest raise? If you're not seeing the chest raise, make sure there is a good seal. Check the mask, check the position of the head and jaw. Use 2% technique if that is not working. If that is not working, consider for an supraglottic airway device. If that is not working, increase the inflation pressure. If that is not working, over the mouth, if required, do end suctioning. If that is not working, go for an advanced airway like an tracheal intubation. Make sure you can give 3 inflation breaths and where you can monitor for the chest rise, which is very important. You need to see the chest rise. Next thing is acceptable pre-ductal SpO2. Let me break down this. This is important concept. There is an ductus arteriosus here. Before this, you need to check for the SpO2. That means you are checking in the right arm, right upper limb to be more precise, right upper limb where you are checking. You do not want to check anywhere else because the ductus arteriosus will connect to the aorta and it will mix the deoxygenated blood with the oxygenated blood. Ductus arteriosus will remain patent soon after the birth so that you will not get an accurate reading. So you need to always check in the right upper limb for the SpO2. In the right upper limb in the SpO2, at 3 minutes acceptable is 70 to 75. At 5 minutes acceptable is 80 to 85. At 10 minutes acceptable range is 90 to 95. After 10 minutes, like a normal human being, it is acceptable is more than 24%. So you need to titrate the oxygen what you're giving to achieve this SpO2 targets. Not at 3 minutes you're targeting to get an 98%. No, you should target around 70 to 75. At 5 minutes, 80 to 85. At 10 minutes, 90 to 95. What do you need to target? What if baby is preterm? That means less than 32 weeks it is. Place the undried body in a plastic bag and place it in a radiant heat so that the patient doesn't go or the baby doesn't go into hypothermia. Immediately consider giving an FiO2 of 30%. Here for inflation breaths, we were considering only the room air. Here we wanted to give an 30% FiO2. If not breathing, they want you to increase to 25. Inspiratory pressure of 25, PEEP of 5 to 10, and FiO2 of 30% what they want you to give it. So this is the newborn life support what you need to be aware of. Very much similar. What they are not mentioned is the color here. Rest everything is similar. The only thing is they have modified the table how it appears a little bit. Otherwise, everything what they have mentioned is pretty much similar. Remember that always ask for help. That should be your first step as mentioned in the class previously. Thank you everyone. This was the update for